The purpose of this video is to review steps for successful surgical treatment of Bankart lesions. In this repair, I'll be utilizing Smith & Nephew instrumentation and implants. I will discuss portal placement and the technical aspects of this procedure while the patient is in the lateral decubitus position. With the patient in the lateral decubitus position, an examination under anesthesia is performed. Range of motion is assessed with forward flexion, external and internal rotation at 90 degrees of abduction, and external rotation with the arm at the side. A load and shift examination is performed on the right shoulder in the anterior superior, straight anterior, and anterior inferior locations. With forward flexion and crossbody adduction, the shoulder demonstrates considerable glenohumeral joint instability. The posterior portal is palpated at the equator of the humeral head after the bony landmarks have been identified. An incision is made and a 4.5 mm Dionix metal cannula is introduced, followed by a 5.5 mm Dionix cannula placed over a switching stick. The glenohumeral joint is viewed through the posterior portal. When establishing the anterior portal, use an arthroscopic needle first to make sure that the tip of the needle is able to touch each structure within the joint. An incision is made and a 5.0 Dionix ClearTrack cannula is introduced through the rotator interval. A 4.5 mm full radius Dionix shaver is introduced to flush the joint. The long head of the biceps is checked for structural damage and stability. The supraspinatus, the subscapularis, the glenoid, and the anterior inferior labrum are visualized. The anterior capsule is intact, as is the superior labrum. The camera is removed from the posterior portal and two switching sticks are inserted. This allows for the cannulas to be switched easily. The arthroscopic view is now through the anterior portal, allowing an excellent view posteriorly. The joint is then debrided. A probe is introduced to assess the posterior labrum. The tear begins at the posterior superior labrum and extends inferiorly to comprise the posterior Bankart lesion. A chondral flap is also demonstrated here and has subluxated inferiorly. A grasper is then introduced to remove the chondral flap through the posterior portal. The posterior lesion is debrided using a 4.5 mm full radius Dionix shaver. An elevator is then introduced and is utilized to mobilize the tear. A motorized shaver is then utilized to further debride the soft tissue off the neck of the glenoid. A 2.3 mm curved osteoraptor guide is introduced. The curve on the guide allows for varying angles for placement of anchors. In this particular case, the guide is directed onto the face of the glenoid in order to cover the area of lost coverage and to also reattach the labrum. The drill is introduced into the guide and then removed. The curved anchor is then malleted into place while holding the guide steady. The inserter is then removed and the anchor fixation is assessed. An arthropierce is introduced and the soft tissue is penetrated slightly inferior to the anchor placement to allow for a capsular shift as well as labral reattachment. The suture is then tied using an arthroscopic knot and advanced with the knot pusher. Care is taken to keep the suture knot off the face of the glenoid. The capsule is shifted superiorly, the labrum has been reattached, and coverage is achieved over the glenoid. The curved osteoraptor guide is reintroduced again and a second anchor is placed. Note that the first anchor is approximately in the 7 o'clock position. The second anchor is at the 9 o'clock position. The sutures are tied and cut. The third anchor is at the 11 o'clock position on the glenoid. The curved guide allows for numerous options for anchor placement as demonstrated here. The obturator is removed and the drill is introduced. The anchor is placed and tested for fixation. The suture is advanced into the joint and the arthropierce is utilized to pass the sutures. An arthroscopic knot is tied and sutures are cut. The repair is now complete. The arthroscope is removed from the shoulder and the arm is now taken out of the balance suspension arm holder. Range of motion and stability are checked once again to conclude the case.
Postoperatively, the patient is placed in a shoulder immobilizer in neutral rotation for 6 weeks. Internal rotation is limited to the abdomen until 12 weeks postoperatively. At that time, activities are advanced as tolerated.